हेलो फ्रेंड्स, वेरी गुड इवनिंग टू ऑल ऑफ यू। कैसे हैं? हेलो हेलो, गुड इवनिंग रोजी, अनुपम, सई, अफसल, केशव, वासुदेवन। सो वेरी गुड इवनिंग टू ऑल ऑफ यू। हाउ आर यू ऑल? कैसा चल रहा है? सो ओके, विल वेट फॉर अ मिनट or 2 minutes for let's all other friends to join, and then we will start our session. Okay, so we'll wait for a minute or two. So how is the live going on? All well? Great, great, great. So hello Shankar, hello Anisha, Mohammed, Imran, Chandni. So very good evening to all. Great, great, great. So I'm very sure that pulse and blood pressure must be jumping up and down, but I know that you are all the very confident doctors, so you are able to control all these up downs of your vitals. Okay, so you are making yourself calm, quiet, confident, and focusing on your studies. Great. So okay, we can start the session now. So again, hello my dear FMG doctors, very good evening to all of you. As we know that our examination date is approaching, and I'm very sure that you all must be busy with your studies. As we know that this session is mainly to identify our area where we can make the mistakes, and we have to understand that why we had made those mistakes, and we have to learn how to rectify. So we are not going to repeat these mistakes in our upcoming examination. So mind my words, if you are able to rectify those mistakes, you are going to get 10 to 15 extra marks in the examination, and really that will be bonus for all of you. Okay, so before starting the session, I just want that all of you should take a pledge with me. Okay, so are you ready to take a pledge with me? Okay, yes, yes. So please say with me that I am fortunate enough to make the mistakes while solving my questions, either in the practice session or in my weekly test or in my subject test, or could be in the upcoming mock test. And I am very thankful to God that God is giving me opportunity to understand those mistakes and to rectify those mistakes in time. And final pledge is that I have to promise to myself that I am not going to repeat these mistakes again in the examination. So that is the most important part of your pledge, is that you have to promise to yourself that if you had identified your mistakes, then you are not going to repeat those mistakes in the examination, because the success is being achieved by those person only that who either they learn from their mistakes in time, or they learn from the mistakes of others and they are not going to repeat the mistakes in life. Okay, so doctors, are you ready to begin our session? And here we are trying to learn that how we are solving our questions smartly with the knowledge and confidence. Okay, so the first area of concern is the maternal mortality. Now here if a question is asked that calculate the maternal mortality ratio. So the first question should come in your mind that what is maternal mortality ratio? The maternal mortality ratio is, it is the number of the maternal deaths per, this is a very important point, that it is not per 1000 population, not per 1 lakh population, not per 1000 live births, it is per 1 lakh live birth. So this point is clear in your mind that the maternal death is per 1 lakh live births. Now second point is if they tell you to calculate the maternal mortality ratio. So we are now clear in our mind that we have to see that it should be per 1 lakh live births. Now if in this given question they are saying that per 1000 live births, the maternal deaths are. So obviously we have to convert into the per 1 lakh. This is one important point. Now if you say that the total deaths they had been given as 6, but if you are again clear in your mind that what the maternal deaths are, the maternal deaths are the deaths either related to the pregnancy or it is aggravated by the pregnancy but not due to accidental or the incidental causes. So we have to exclude this death which is happening because of the road accidents. So now see that those who are including this road accident as a maternal death and they are counting as per 1000 live births, they will go with the answer 6, that is a wrong answer. Now if they are excluding the road accident but still they are going with per 1000 live births, they will go with the answer 5, again this is wrong. And if they are calculating per 1 lakh live births but they are not able to exclude the road accident, they will go with the answer as 6000, that is again a wrong answer. So you have to go with per 1 lakh live births, you have to exclude the accidental deaths. So the correct answer is, it is a 5000. So here the point to remember is that maternal death means the time it is from the conception till 42 days after the delivery. So few more questions that what periods are included in the maternal deaths. It is all the three, the antenatal, natal and the postnatal. The next question, which is the most important period, it is the postnatal period. What is the most important cause of the maternal death? The direct cause is the hemorrhage in the postpartum phase, and that is the postpartum hemorrhage, and the indirect cause is anemia. Now the another important point is, as many of the deliveries they are happening in the periphery and they are not writing the exact cause of the death. So now the technique has been designed as a verbal autopsy, because we know that autopsy is to identify the cause of the death. So here we are doing the verbal autopsy, and that is a rhyme technique is there. So suppose if a team is going to the family who were present at the time of the delivery, and suppose the mother-in-law in the family, she says that doctor, everything was fine, my daughter-in-law has delivered normally, the baby had an immediate cry and suddenly after that there was a gush of blood. डॉक्टर साहब इतना खून बहा था कि पूरी बाल्टी भर गई और बच्चेदानी का गोला नहीं बना, ऐसा सिस्टर ने बोला था. What it means that there was an excessive bleeding after the delivery, that whole of the bucket was full with the blood, and usually the uterus is contracting after the delivery and its feeling is like it's a firm to hard globular mass is there, and that has not formed at it was told by the sister. It means the uterus was not contracting, atonicity was there, and there was an atonic PPH. So in this way we can identify the cause, that might be the atonic PPH that has caused the death of that lady. Now another example could be mother-in-law is saying that doctor, my daughter-in-law was having the very good contraction, but a sister says that a baby is not coming down. So what she had done, doctor, वो टेबल के ऊपर चढ़ गई थी और उसने वहां से उसका पेट दबाया और बच्चा बाहर आ गया. And what she says that a sister had just on the top of my daughter-in-law and she had pressed from the above and the baby is out. And suddenly my daughter-in-law collapsed and she died. This means the lady was having the good contraction, baby was not coming down, it means it was an obstructed labor. And as the sister had pushed from the above, might had caused a rupture uterus leading to the severe intra-abdominal hemorrhage or intraperitoneal hemorrhage, and suddenly the lady had collapse. So by this you can assess that the rupture leading to the hemorrhage could be the cause of the death. So this is what is the Rhine technique or the verbal autopsy. And a few more points are that we should be knowing that what is our goal. The goal of India is that we have to bring down the maternal mortality ratio to 100, and we are just near to that, and current value is 113, and the global goal is, as per the Sustainable Development Goals, by the goal 3.1, that we have to bring down our maternal mortality to less than 70 by 2030. So this is all what we should be knowing about the maternal mortality ratio. Then the next area of concern is about the various pediatric mortalities. Now suppose if a question is asked that we have to calculate the infant mortality rate. So immediately the question should, or the reel should flash in your mind that what is infant mortality rate. So infant period is the 0 to 1 year period, and it is expressed as per 1000 live births. So this is important. So in this question, if they say in the village the 500 live births took place and 5 children they died before the 1 month, so this is your neonatal death, because before the 1 month is the death is the neonatal period, and the 15 more died between the 1 month to the 12 months. So this is a post neonatal period. So while calculating the infant mortality rate, we have to calculate both the neonatal and the post neonatal. So my total infant deaths will be the 20, and the catch is that those who are going with the 20 without looking that this is out of the 500 live births, they will go with the answer 20. Again, that is a wrong thing. Clear? And those who are knowing that this is per 1000 live births, then definitely they will go with the, because we have to double this value, so they will go with the 40. That is the correct answer. And those who are thinking that it is a per 100 live births, they can go with the 400 also. That is also a wrong answer. Same, another question could be where they are asking again to calculate the infant mortality rate. But here what they had given, they had said that 10 children they died before celebrating their first birthday. It means they had given the answer of the infant deaths that it is 10 children they die before their first birthday. But a catch is here they had not given the how many live births are there. They had given the total population as the 5,000, and they had given the rate of the live births as 50 per 1000 population. So first we had to calculate that how many will be the live births in the 5000 population. So your answer should be the 250 is the total live births, and out of these 250 total live births, the 10 children are dying before celebrating their first birthday, and we have to convert into per 1000. So we have to convert in the 4 times, because here we are not doing any rocket science in the calculation. We have to only apply the common sense, because we are not being provided the rough page or the pen in the examination. So for out of the 250, the 100, so obviously out of the 1000 we have to just multiply as a 4 times, and the answer should be the 440. That should be the correct answer. But suppose if they are not able to either converting into the 1000, or they are not able to calculate as per the 5000 live births, they are only thinking that this is the birth rate as the 50, then definitely they will be going as an answer 10 infant deaths are there out of the 50 live births into per 1000, then definitely they are getting the answer as the 200. That is a wrong answer. So we should be very clear while solving the questions that answer or the definition and the formula should be in your mind, and we should be very clear that what is a numerator, what is a denominator. And what the denominator you can say is the down one, and is the denominator and the multiplying factor, and based on that we have to answer the question. Now if I say another question is that a question they are saying that at the 34 weeks of the pregnancy, the baby had or fetus had the absence of the fetal heart rate, which has been confirmed by an ultrasound. So this mortality will be included in the calculation of the which parameter. So here it is the intrauterine death. So obviously it will not be included in the neonatal mortality rate, because neonatal means after the delivery in a first of 1 month. That is the neonatal. What is an infant mortality rate after the delivery within the first 1 year? Again, this is out. Post neonatal, again after the first 1 month till 1 year after the delivery. So this is out. So this is included in the perinatal mortality rate, because peri means around. So around is what? From the 28 weeks of the pregnancy till the delivery, during the delivery, and the first 7 days after the delivery, what the mortality is, that is included in the perinatal mortality, and we have to express again per 1,000 live births. Then the next area is your growth monitoring. Now here, we all know that growth monitoring is done in the ICDS centers by Anganwadi workers, and we are using the growth chart, and that what we call as an ICDS growth chart, which is looking like this, and this is also known as a MGRS growth chart. Now, while reading the question about the growth monitoring, now this growth chart should immediately come into the mind, and the points what should flash immediately in your mind, that it is having the 3 lines and what these lines are representing. So the first line, it is representing the 50th percentile or the median. The second line is representing the -2 standard deviation, and the third line is representing the -3 standard deviation. And as we all know that the area between the first and the second line is the green zone, it is normal. The area between the second and the third line is the yellow zone, it is the mild to moderate undernutrition, and the area below the third line, it is the red zone, that is the severe undernutrition. Clear? So this thing should come in your mind quickly within a second or two. It should not take more than that, because once this concept is there, now you have to read the question very carefully. Now suppose if a question is like this, that in the ICDS growth chart, the second line represent, and we know that a second line is not representing the 50th percentile, because it is represented by the first line. Now be very careful. In your mind it is the 2 standard deviation, but examiner has given the +2 standard deviation first. So not to be trapped in the net of an examiner. So again, this is not a plus, because plus is towards a higher side. You are talking towards a lower side. So this is your answer, that a second line is representing, you can remember like as a second line as 2 standard deviation, but it is towards the lower side. So this is minus. And the third line is representing the -3 standard deviation. Again, this is not an answer. So in the ICDS growth chart, the second line is obviously representing the -2 standard deviation. Now another question could be that what are the best parameter of the growth monitoring? Because we know that weight for the height, it is only suggestive of the acute malnutrition, that is not a best parameter. The weight for the age, yes, it is presenting both acute and chronic malnutrition. So obviously we prefer this parameter. The height for the age is suggestive of the chronic malnutrition, then definitely it is not as a best. So obviously the weight for age is the best parameter. Now if a question is asked like this, that if a mother is bringing a baby as 0 to 6 years, so here just to revise that what are the beneficiaries of the ICDS centers, as we had remembered with the mnemonic, the children 0 to 6 years with their mothers and their bodyguards. And we know the bodyguards are nothing but the adolescent girl in the family or adult reproductive age group women. So these are the beneficiaries of the ICDS centers. So if a mother is bringing the baby and she says that the growth is being monitored, and Asha workers, Anganwadi worker is the heart of these ICDS centers. So when Anganwadi worker says that which babies are considered as the malnourished babies. So babies, as we know that below the second line, below the green zone, they are considered as malnourished. This is in our mind. So now we have to read the options very carefully, and here we require the full concentration. above the first line it is a not, below the first line again this is not, below the second line a yes, and above the second line again this is a not. So here the correct answer is it is below the second line. It is the area of the malnourishment. Now they are not mentioned it's a mild, moderate or the severe. So malnourishment or undernutrition it starts below the second line. Now here I just want the one promise from all of you, because what happens on the day of examination you are very much stressed, and the day before the examination you may not be having a sound sleep because you are following a pattern that you are reading till late night or early morning, and during the preparation you are getting up at late in the morning. So dear doctors, you have to promise me today that at least a week or 10 days before the examination, you are going to change your sleep pattern. So you are going to sleep latest by 11:30 or 12, make a habit to get up at 5 o'clock in the morning, and you should be having a sound sleep. Then only you are able to concentrate, recall the concepts, connect the dots, and should come to the correct answer, because otherwise in the examination the everything appears to be close, and that's why we say that options are very neck to neck. But it is very clear if you are clearly reading the points and you are able to reconnect the dots, then you will come to the correct answer. Okay, and one more point about these ICDS centers, that what functions they are doing, and these are being responsible for giving the vaccination, for doing the growth monitoring, then they are doing the supply or providing the midday meal to the children. They are doing the referral services, means if they are examining the baby and the baby is coming to be an affected or the malnourished baby, then they are referring the baby to the higher centers. They are giving the non-formal school education to the children and giving the health education to the mother or adolescent or the reproductive age group woman in that area. And these centers, they are being controlled by the Ministry of the Women and Child, and this is the logo of the ICDS centers, and they are covering a population of 400 to 800 in the village or in the plain area. So this is all what you should be knowing about the growth monitoring. The next area of concern is the caloric requirement. Now in the caloric requirement, the points what we have to remember is, one, whether they are asking for the male or female. Second thing is that what is their work style, whether they are the sedentary worker, moderate worker or the heavy worker, and if she is a female, then what additional situation is, whether it is related to the pregnancy or related to lactation. Whenever a long question is given, always try to read the last 2-3 lines, see the options. Many times you can come to the conclusion that what examiner is trying to ask from you. Okay, so if a question is that calculate the caloric requirement by the sedentary worker woman. Now here we had come to know the 2 points, that they are asking about the female and the lady is a sedentary worker. And we know that the caloric requirement, basic calories by a sedentary worker, a woman, is the 1700 kilocalories. And now the question is that they are saying that who delivered a stillborn baby 3 months back. Now you are, if reading that as that baby has been delivered the 3 months back, obviously she must be lactating, and you know that during the lactation the additional calories we are adding as 600 calories in the first 6 months. So definitely you are going to add the 600 calories and your answer is coming as 2300 calories. Now please listen carefully that this answer is a wrong answer. Now you must be thinking why? Because only the catchword is that the baby born was the stillborn baby. This is the main catch. The baby born is the stillborn baby. Still means the dead baby is born, and obviously the dead baby, then the mother is not lactating. So the mother is behaving like a non-lactating mother. So is requiring the basic calories that is required by a sedentary woman. So here the correct answer is the 1700 only. Okay, so this is the important catch, is that this a stillborn baby is a very, very important catch. Now suppose another question is the same like, and if they say that caloric requirement by a lactating mother. So here they had clearly mentioned that it is the lactating mother who delivered a 3 months back, okay, and heavy worker by occupation. So here they had clearly mentioned that it is an heavy worker, a female who delivered the 3-month back. Obviously the baby is alive because she is lactating. So here we should be knowing that what are the caloric requirement by a heavy worker, and as we very well know that we had remembered by the trick that the basic calories is the 1700, you have to add the 4 to get the calories by a moderate worker, that will be the 2100, and in the 2100 you have to add the 6, that is the calories required by a heavy worker female. Okay, now here this is the basic requirement, and in this basic requirement you have to add the extra calories required during the first 3 months of lactation. So those who are thinking that it is plus 350, they are wrong, because 350 is required in the pregnancy, that is an additional calories. Now earlier we used to say the 500 calories are required during the lactation, so this is also out. Now we are saying the first 3 or the first 6 months we are requiring the 600 extra calories, and after the 6 months it is a 520 calories. So this is your correct answer. Now please listen carefully. Now if you had thought that the 600 extra calories are required and you are adding the 600 in this basic calories, your answer will be 3300. So you are thinking in the mind that you had added the 600, so you might go with this option also. Here you had added, you are right, but they had split the values. So be very careful, don't add in this situation because they are giving you the additional plus values. So here the correct answer is 2700 plus 600 calories. Okay, so this is what is the catch to solve the questions, and we have to identify in what place or at what areas we can make the mistake. We know the things, but only that we have to see the options very carefully. In what format the examiner is trying to ask from you, you have to answer in that format only. That is a very, very important point we have to remember during the examination. Clear? Now, just to revise that what are the basic calories required by male. So the moderate worker female calories is required by the sedentary worker. You can remember, भाई आदमी लोग ज़्यादा खाते हैं, औरतों को खाने को नहीं मिलता. You can remember like this. So moderate worker calories is required by a sedentary worker male. So sedentary worker male is the 2100 calories. You have to add a 6. That is 2700 will be the heavy worker, it's a moderate worker male requiring the calories, and you have to add plus 8, that will be the 500 calories required by a heavy worker male. So these are the various caloric requirement by the individual in the different age group. Now another area is about the vaccine contraindications. Now very, very commonly asked area, and sometimes we do the mistakes. Now please remember here the point that we should be knowing that live vaccines are mainly contraindicated in which situations. And the second point is that we have to choose the best option from the given choices. That is very important. Suppose in the one situation it is said that a baby is having some problem in the immune status, means immunity is poor, and what vaccine will be contraindicated. We know that if immunity is poor, all the live vaccines are contraindicated. So here in the option we have to quickly revise that which are the live vaccines, which are the killed vaccines, which are the toxoids and other vaccines. So we know that a TT or the TD, it is a toxoid vaccine, so it is not contraindicated, can be given safely. The measles and the MMR, yes, it is a live vaccine, so obviously it is a contraindicated. Then DPT is a combination of the diphtheria is a toxoid, pertussis killed vaccine, the tetanus is a toxoid. So again this is not contraindicated. The killed injectable polio vaccine is again a killed vaccine, it is not contraindicated. So they are asking which vaccine is contraindicated. So here the correct answer is the measles or MMR vaccine. Clear? Now another situation where we are having the poor immunity is the pregnant woman. So again remember the point that in the pregnancy the killed vaccines can be given safely, the live vaccines are contraindicated, but if we are requiring for quarantine certification, then yes, yellow fever vaccine can be given if it is required, and rubella vaccine is absolutely contraindicated because of congenital malformation possibilities. So here the question is that all the vaccines can be given safely to a pregnant woman except now rabies vaccine. Now rabies vaccine is a killed vaccine, so it can be given, okay, and typhoid is a killed vaccine and live both, but they are asking that a typhoid kill, so it can be given safely. But a rubella vaccine, it is a live vaccine, so this is contraindicated. Hepatitis B is again is a kill vaccine we can give. So here the answer to this is the rubella vaccine. So here quickly we'll revise that what are the various live vaccines, as we had already remembered with the mnemonic, that is baby Mirai Archela is the BCG, the measles, mumps, rubella, rotavirus, yellow fever and the chickenpox. These are the vaccines which are in only live form. And what are the vaccines which are only killed form that we had remembered with the mnemonic as an HAPIC is the hepatitis B. We are having the rabies and the pertussis vaccine, that this is the vaccine which are available in only killed form. Now we had some vaccines which are available in both live and the killed form, and that is the polio vaccine, we had a Japanese encephalitis vaccine, the influenza vaccine, the typhoid vaccine, cholera vaccine. So these are the a few areas we should be knowing, that what are the live vaccines, kill vaccines, toxoid vaccines, and what are the contraindication of the vaccines, very commonly asked, and we have to go with the best answer from the given choices. Remember this point. Now, another very commonly asked area is that as per our national immunization schedule, that at what time what vaccine has to be given, and they ask that if a mother is bringing a child at a later time, then what to do. Now here the 2-3 things should flash in your mind simultaneously. The one is that what are the vaccines given at what time as per our schedule, and the second is what is the delayed immunization schedule. Clear? So here I'll tell you the trick how to go smartly, because here we have to focus on our time management also, and we have to come with a correct answer, because this is appearing like a very long question, very long options are there, and it is quite difficult to identify the correct answer within a 1 minute. So see how we have to work smartly. Now they are saying that a baby has been brought at the age of the 11th month. This is a one thing, that baby has been brought at the 11th month of the age. Now we should be knowing that what vaccine the baby had received. Now the another line says that the parents are giving the child had received only the birth dose of the vaccine. Now with this line, we are clear that the baby had received the BCG vaccine because it is given at the birth. Baby had received the oral polio vaccine 0 dose, and the baby had received the hepatitis B vaccine, that is the birth dose. So here the baby had received these vaccines. Okay. Now at the 11th month, if you go with a delayed immunization schedule, we know that rotavirus cannot be started after 8 months, not in a single dose can be given, and if you are starting at a first time, that it should be started below 15 weeks. So at 11th month, we cannot give the rotavirus. These two things in our mind, that BCG baby had already received and rotavirus is not given. Clear? So now the option is they are asking that which vaccine can be given. Now in the first choice they say that it is the BCG. So BCG child has already received, we are giving only the single dose, so this is out. So you are not supposed to read the whole choice, because whole option you are not supposed to read, because it cannot be given, the baby had already received the BCG. Now if we just read the first vaccine, OPV, this could be the possibility, OPV, this could be the possibility. I am not reading the whole option. And rotavirus, again this is out, because we cannot start the rotavirus at this. So by a smart action, you had already ruled out these two choices. So, not going to read the whole option and wasting your 15-20 seconds. No, there is no need. Now, we have to see these two choices only. Now, the choice, if I go with the B, OPV can be given, the DPT can be given, rotavirus again, this is not given. So, this is choice is also out. I am not going to read the further choices. Now, I am left with the one choice only, and that is my answer, but still for the doubly sure, I will read the whole choice that OPV can be given, the DPT can be given, a vitamin A can be started because it is a 11-month-old child, MMR is also given, hepatitis B is also given because it can be given less than 1 year age, pneumococcal can be given, the HIV vaccine can be given. So, here the correct answer is option number C. So, see how smartly we had saved our time and we had come to the correct answer. Okay, so in this way you have to work smartly with your knowledge, because knowledge is very important. Until unless you are not knowing that what vaccine we are giving at the birth, what vaccine has to be given at the 6 weeks, 10 weeks, what if you don't know what is a delayed immunization schedule, that definitely you cannot come to the answer. So, you have the knowledge, basic knowledge, and you are working smartly to save your time and to come to the correct answer without having the confusion. So, this should be our strategy. Another very commonly asked section is from the storage, and in the vaccines which are very heat sensitive, we are having a special sticker, that is the vaccine vial monitor. And in the vaccine vial monitor, we are having the inner square, and that inner square is coated with the heat sensitive chemical, and when this vial is exposed to the high temperature, it is changing its color, and this will give us an idea whether vaccine has been destroyed by the excessive heat or not, and whether we can use the vaccine or not. So, if a question is asked about the vaccine vial monitor, so this chart should be coming in your mind immediately, that if a inner square is white, it's a grade 1 can be used. If the inner square is having a light blue color but a lighter than the outer one, grade 2 can be used. But if the inner square is of the same color as an outer one, it is a grade 3 cannot be used, and if it is the darker than the outer one, it is a grade 4 cannot be used. So, keeping this concept in the mind, and the question is that if the vaccine vial monitor is having the dark purple color, so the sister is asking from his senior doctor that what to do. So, what is an advice of the senior doctor? Because it is a dark purple means a grade 4. So, we cannot use, we have to discard. So, we have to find this answer because we know the answer, and then we have to find the answer in the given choices. Now, don't worry, give the vaccine. No, we cannot give this vaccine. Discard the vial, use another new vial. This is the correct answer for this, because we cannot give the vaccine in the double doses also. We cannot keep the vaccine in the freezer and can again use it tomorrow. No. So, we have to discard and we have to use another new vial. Now, opposite to this is we have to remember about the freeze sensitive vaccines, means those vaccines if they had been exposed accidentally to the low temperature, means by mistake if the staff has kept those vaccines in the freezer or in a lower part of an ILR where they had been exposed to a very low temperature, they can also be destroyed, and we can check their efficacy by the shake test, and usually the T group of the vaccines like a DPT, TT, TD, hepatitis B, these are the very freeze sensitive vaccines. So, their freeze damage can be assessed by the shake test, and the heat damage is assessed by the vaccine vial monitor. Now, another area is that how to identify the various type of epidemiological studies. Now, before going to the question, now I'll just want all of you to understand this picture, and it should be in your mind, because for identifying the studies, the two things we have to look in that particular study, the number one is the direction. So, if a direction is at that particular time only, it can be a cross-sectional study or the ecological study. If we are going from this current position or the current time to the backward, our direction is backward, then it is your case control study. But from that point, if you are going forward, then this is your prospective cohort study. Now here I want to add one more study. If we are starting at this point, we are going a little bit back and then coming forward, then this is becoming your retrospective cohort study. And if a retrospective is further continued as the prospective cohort study, this becomes your mixed cohort study. Clear? So this is the one point that we have to look for the direction. Now the second point is that you have to look for whether the result what we are looking for is present at the beginning of the study or not. If the result is absent, then this is the only one study, that is the prospective cohort study, where the result is absent, while in rest of all the result is already present with us and we are doing the different studies based on the direction. So this concept should be in your mind while answering this type of question. Now let us see the question. The question says that if we are studying a maternal smoking history during the pregnancy, okay, and we are taking the smoking history. Now, not to confuse that history is always taken in the case control study. No, they are saying when they are starting the study, they are starting a study in a pregnancy. And what they are trying to do, they are trying to take a smoking history and they are examining or starting this study in the first prenatal or the antenatal visit, and they are subsequently assessing, means from the pregnancy in the first visit they are following this lady till the delivery point. So they are going in a forward direction from the pregnancy to the delivery. Now forward cannot be from the delivery to the pregnancy. So they are starting the study in the pregnancy, although they are taking the history. So no confusion that always the history is taken only in the case control. So see, when we are starting the study also, so we are starting in the pregnancy, following this lady till the delivery, and then we are analyzing that those ladies who are the smokers, what is the baby weight after the delivery, and those ladies who are non-smoker, what is the baby weight after the delivery. So we are going in a forward direction because in the pregnancy we don't have the birth weight right now. So obviously this will be your prospective cohort study. Clear? But suppose if they had said like this, that a study started in the month of April 2019 and where the labor room record of the patient admitted in the month of March. So common sense that March is coming before the April. So if they are starting a study in the April month and obviously they are collecting the record of the March of the same year, it means they are going little bit back in the month of March who had been admitted in the labor room, and obviously patient is admitting in the labor room, then she is going to deliver within a day or two. So it cannot be a forward study. So we are going back to the labor room when they are admitting, and they are trying to analyze that those women who had been given the oxytocin and what is its effect on the neonatal outcome. So they had gone back and then they had analyzed and they are coming forward. So this is your a retrospective cohort study. So in this way we have to analyze and we have to find out that what can be this study. Now another area is that we should be knowing that what parameters we can calculate by the various studies. Now here sometimes the examiner wants two things from you. That first, that you should be able to identify what the study is, and the second is you should be able to know that what parameters can be calculated by that study, and the third thing the examiner can add the value. Means you have to do all these three things in a 1 minute time under pressure. So this is very important. Now if I say that simply, that if a question is asked the parameter calculated by the case control study, we very well know that it is the odds ratio, and we know that a relative risk, incidence, attributable risk and the population attributable risk is calculated by the cohort study, and prevalence is calculated by the cross section study. So this thing should be in your mind, and this should be very clear that these are the parameters. Now coming to the next question, if they ask, this is a question. The question is that they are asking that what parameter is calculated with its value. So first look at the options. They are saying odds ratio and the relative risk. It means I have to differentiate only between the case control and the cohort study. Now forget about the cross sectional, forget about the RCTs, forget about the ecological study. So in this way you had centralized yourself that you have to think only the odds ratio and the relative risk, means the case control and the cohort study. And I know the difference is the direction and the outcome in the beginning of the study. Clear? Now, I'll read the question. The study conducted on the 50 patients of the deep vein thrombosis. Now, here you are getting the hint. Now, study is conducted on the 50 patients. So, we know that case control studies is started on the patients and then we are going back. If it is a cohort study, then we should be saying the study started on a 50 individuals who are using the oral contraceptive pills and they are looking for the deep vein thrombosis. So that will be your cohort study, but a statement says that a study is conducted on 50 patients. So now your answer is that this is your case control study and I know the parameter calculated is the odds ratio. So these two options are out. I am not looking for this, that they are not talking about the relative risk. Clear? Now I have to see about the odds ratio, and the one more difficult is that they had given me the either this is a 4 or the 6. Now, it's very difficult because I'm not having any rough paper or the pen, because I had learned that by doing the 2 by 2 table, I can only calculate the odds ratio because this is the cross product ratio. But still, I'll tell you the trick. Now, if they are saying that in the 50 patients of the deep vein thrombosis, the history of the OCP use was in only 20. So, risk factor was present in only 20, and out of the 50 healthy individuals, the risk factor was present only in the 5. Now, if we say the risk factor is 4 times higher in the OCP users of the deep vein thrombosis, clear? But remember, now this is the direct relationship is in the relative risk calculation, because we calculate by the formula of the incidence in exposed by non-exposed. But in the odds ratio, we are not having this formula. The formula is the cross product ratio, that is AD upon BC. So this will not be the same proportion. So we know this basic concept. So I am very sure that this cannot be the 4. So if I am not doing the calculation, and I can say this could be the answer. But as I have to justify this answer, so if I say that this is the table of what we know, that we should be knowing to calculate our, just a minute. So this is the table. I know that I have to prepare this 2 by 2 table to answer my question. Now, the odds ratio, I know it's a cross product ratio, and this is my column as A, this is the B, and this is the C and D, and my odds ratio is the cross product ratio. And now the trick is that how I'm going to fill the values. Now they say the total disease patients are 50 and the total healthy individuals are also 50. And out of these 50, only the 20 are giving a history of risk factor, that is the OCP use. So this value is 20, so obviously my C value is 30. Now in the healthy section, they are saying that only 5 are giving the history of the OCP use. So remaining 45 are not using the OCP. So my odds ratio will be 20 into a 45 by 30 into a 5, and that answer will be 6. So I had not done this major calculation, which may require my 1 minute or the 2 minute, and I'm very sure that most of us cannot do without the rough paper or the pen in the examination by the mental calculation. And because अगर हमारा मैथमेटिक्स इतना स्ट्रांग होता, so we could have gone towards a mathematics stream and we could have become engineer. But as our maths was weak, that's why we had gone with the bio and we are studying the medical science. So what I mean to say that with this question, you should be able to exclude the points. So first thing what we had excluded is that this is not a cohort study, so we had excluded the relative risk options. Second point is that we know that it is not a directly proportional of the individual having the risk factor or the without the risk factor, so it cannot be 4 as the ratio is 4. So the last option which is left should be the answer for this question. Clear? And here we should also knowing the formulas of the these parameters, because again they are very commonly asked. So relative risk sometimes they ask as a risk ratio. So no confusion, relative risk is a risk ratio, incidence in exposed by the non-exposed. The attributable risk is the risk difference, that is incidence in exposed minus non-exposed by the exposed, and the population attributable risk is the incidence in total minus non-exposed by the total. And the odds ratio we had already discussed is the cross product ratio, that is AD upon BC. So this is what we should learn. Now, another very commonly asked area is the formula of either of sensitivity, specificity, positive and negative predictive value. Now, as I always say you, and again I am saying, that we had discussed a very simple trick to remember the formula. Because if you look at the options, now everywhere you are finding only the true positive, false negative, false positive, false negative. पागल हो जाओगे आप option देख के, and you are not able to choose the correct answer. Clear? Now, we are very well able to remember that sensitivity is the true positivity and the specificity is the true negativity. Clear? And we know that a positive predictive value means it is positive and the negative predictive value is the negative. Clear? So, if you are seeing that they are asking us to know the formula of the positive predictive value. I know it is positive. So, your numerator should be the true positive. This is the first thing you should remember. Now, you see in the options, so this could be my possibility because this is true positive as a numerator. True negative, this is out and this is out. Now, I am left with only the two choices. Now, only I have to just focus on these two choices. यहीं पे दिमाग लगाना है, इधर उधर नहीं लगाना है. Okay. Now, the second point I always tell to you that in the predictive values, positive means the denominator should be positive. So, the formula for the positive predictive value is all positive, that is the true positive plus false positive. And for the sensitivity, the formula is opposite to the positive, that is the true positive by true positive plus false negative. So, I know that all positive is the formula for the true positive value. So, I will look for the denominator. So, this is true positive plus false negative. So, this is out and I am left only with the one option, that is the true positive by true positive plus false positive. Okay. So, this is my answer. Okay. Now, if we quickly revise the formula of the negative predictive value or formula of the specificity. Now, we know that it is the negative. So, if it is the true negative in the numerator, then if it is all negative, that is the true negative plus false negative, this becomes my formula of the negative predictive value. And if it is opposite to the true negative, that is true negative plus false positive, this becomes my formula of the specificity. So, in this way you can remember. So, you know the concept, only you have to find the correct answer. So, saving the time, coming to the correct answer is the smart way to attempt the examination. Clear? Now, another very commonly asked section and creating a confusion is the relationship between the parameters, and especially they are asking the relationship with the prevalence to the predictive value. Clear? Now, if we say the question as the change in the prevalence of the disease will affect. Now, if a prevalence is changing, now it will affect the predictive value. And predictive value, both the type of the predictive value, the positive as well as the negative predictive value. Okay, so this answer is also correct. It is affecting only positive predictive value because this is affecting but not the only. And only negative predictive value, so I can say this is affecting the negative predictive value but not the only. So the best answer is that it is affecting the both. Okay, but suppose here the answer or the choices is that not the only word, it is affecting the positive predictive value and you are reading only this, that prevalence is affecting the positive predictive value, and you are not reading the other choices, then you can go with this, and in the end it is written as the both. So my another advice is that if you are very sure while reading the options that your first choice or the first option is correct, still give 5 seconds time to look for the other choices. You may find the better answer sitting in the end, or they could be the all of the above, or they could be the both the answers are correct, like that. So why to lose even a single mark for that area which you know. Okay, now using this concept, and if we say that prevalence is affecting the predictive value, but remember that the test sensitivity and the test specificity, it is the inbuilt criteria of a test. Now it is not affected by the prevalence. So remember, like your height is always constant. If you are standing in front of a taller person, you will look as a shorter, and if you are standing in front of a shorter person, you will look like as a taller, but your height is constant. So same like if you are using the same test of the a fixed sensitivity and the specificity in the different areas where we had a difference in the prevalence of the disease in the community, then obviously our predictive value will change, but it is not because of the difference in the sensitivity and the specificity. The difference is only in the prevalence. Okay, so here the question is that if the test what we are using is with the 90% of the sensitivity, 80% of the specificity, and applying in a one area with the prevalence of the 10%, but the same test now means, same means we are not having the effect of the sensitivity and the specificity in an area of the 20% of the prevalence, then parameter affected is, because here the prevalence is changed, so it is not affecting the sensitivity, it is not affecting the specificity, but yes, the predictive value will change. But please listen carefully. If a reverse is asked, that predictive value or the diagnostic power of a test overall depends on what? So predictive value of a test or the diagnostic power of a test will depend on the prevalence, and it is also depending on the specificity and the sensitivity of the test. But if you are using the same test in the different areas, then still if you are finding the difference in the predictive value, then it is because of the differences in the prevalence only, because the same test means the test sensitivity and the specificity is not affecting the predictive value. The culprit is only the prevalence of the disease. Okay, so read the question very carefully. The concept what you have to keep in mind, that predictive value of a test is dependent on the sensitivity, specificity and the prevalence, and the prevalence is affecting the predictive value, that if a prevalence is increasing, the positive predictive value is increasing, and if the prevalence is increasing, the negative predictive value is decreasing. So this is the concept you have to keep in mind, and you have to apply this concept while solving these type of questions. Clear? Now another area of concern is when we are calculating the various demographic parameters. Now one is dependency ratio. Now when the dependency ratio is asked to calculate, now you should be knowing that what is the numerator and the denominator. Now numerator of the dependency ratio means the non-working population, and the non-working population is the population less than 15 years and more than 65 years, and the denominator is the working population between 15 to 65 years. So this should be in your mind, the formula, and as this is a ratio, so this is comparing the two different things. Now coming to the question, they are asking to calculate the dependency ratio. So we have to calculate what is the non-working, what is the working population. Now they are saying that the total population is 10,000. Okay. Now out of this, the 1500 are below 15 and the 500 are above 65. So they had given us the non-working population as a 1500 plus 500, that is the 2000 is my non-working population or the numerator for dependency ratio. Now the catch is that we have to calculate the denominator, that is the working population. The common mistake what we do, that we go with the total population, and if you are going with the total population as the 10,000, your answer will be 0.2, that is wrong, because here they are giving you the total population and they had given you the non-working population. So obviously the working population will be 10,000 minus 2,000. So your correct dependency ratio will be 2000 by 8000 and your correct answer is 0.25. So be very careful that we have to find the working population or the non-working population separately from the total population given. The next is again from the demographic parameters where they ask you to define either the fertility rates or the total fertility rate, gender fertility rate, gross reproduction, net reproduction, or sometimes they ask you to calculate also. Now, suppose if they ask you to calculate the gross reproduction rate. So, here immediately the definition should come in your mind that what is a gross. We had remembered with the trick that this is G for girl. So, this is the total number of the girl children born alive to a woman. Okay. Now, mind the words that should be born alive. If anything happens after the birth, still they are being counted as the rate as the gross reproduction. So, here they had given the obstetric history of a woman. So, we will see carefully. They are saying the first full term male. So, this is out because male are not included in the GRR because it is a girl or the gross reproduction rate. They are not asking about the total fertility, so male is out. Now, the full term female alive a cesarean section. Yes, it is a female and alive, so that is included. Now, the mode of the delivery is not affecting the GRR, remember. Then another point is that the full term female stillborn. Again, the baby is dead at the time of the delivery, so this is also out. So, we are not including this. Now, the next is that the full term female asphyxiated baby vaginally but died in the nursery on the 8th day. So, obviously, baby was alive at the time of the birth, though asphyxiated, but we will be including in our GRR. So, only the 2 girls born alive at the time of the birth. So, the answer for the GRR is a 2. Now, suppose if they say that calculate the total fertility rate. Now, total means the total children born. So, yes, I will be including this male child also who is born alive in the total fertility rate, and my answer 3 will be the total fertility rate. Now, suppose if we say they calculate the net reproduction rate. Now, in this they are saying that one female is dying on the 8th day. So, only this a baby has been left with me, that who is alive at that moment, and I don't know what will happen when this girl will reach to her own reproduction. Clear? So, in this situation, my net reproduction rate is 1. So, in this way, read the question very carefully that what rate they are trying to ask and we have to identify. Now, if they simply ask that what is the crude birth rate, general fertility rate or the marital fertility rate, always remember that they are expressed as per 1000 live births. Okay. Now, if it is per 1000 of what? If it is per 1000 of the mid-year population of the woman in the reproductive age group, then this will be your general fertility rate. But if they are asking as a live births per 1000 of the mid-year whole population, it will be go as your crude birth rate. And if they are asking as a number of the live births per 1000 mid-year population of the married woman in the reproductive age group, it will go as the general fertility rate. And they ask the total number of the children born alive in a woman in her entire reproduction, it is the total fertility rate. So, no confusion, the concept should be clear in your mind. Then another area is that the calculation of sex ratio. Now, here we know that what the sex ratio is, that it is the number of female per 1000 male. This is what the definition of the sex ratio, number of the female per 1000 male. Clear? Now, here the question says that the total population is 10,000 and the 50% are the female. It means if the female are 50%, so obviously the 50% will be the male. This is very clear. So, if I say the ratio of the male to female is 1:1, and if I have to convert into the 1000, I can say again, so this ratio will be the 1000 to 1000. So, there should not be any confusion, because if you think that 50% are the female and that will be your sex ratio, so you may go with this option, this may be wrong. Now, if we say that total is the 10,000 and out of this the 5,000 are the female, you can go that 5,000 is a sex ratio, again this answer is wrong. okay. And if you think that out of this 50%, suppose if you are taking as 1,000, then 500 are the female, then this is actually the absolute number, not the ratio. So ratio is per 1,000. So as the proportion is 1:1, so the correct answer is the 1,000 is your sex ratio. Clear? Then another area is same like as was for the dependency ratio is the literacy rate. Now here again we should be knowing the definition of the literacy rate, and only catch is the denominator, because we cannot expect a newborn baby to be able to read, write and understand in their own language what we define as a literate person. So the age has been defined as either the 7 years or more is the age is as the denominator for calculating the literacy rate. So if a question is given that in a population of the 10,000, the children below 7 years are 2,000 and the literate people are 4,000. So we know that a literacy rate is the number of the literate people by the population of more than 7 years. This is only the catch that given as a population less than 7 years is the 2,000. So your net population above the 7 years is 8,000. Okay. Now the second point is that the literacy, although this is a rate and we know that a rate is expressed as per 1,000, but this is an area where the rate is expressed as per 100. So those who are going as the 400 per 1,000, it is a wrong, because literacy rate is not expressed as 1,000. Those who are not excluding the 7-year population, below 7-year population as the 2,000, they are going with this 500 per 1,000. This is again a wrong answer. And those who are expressing in a percentage, okay, and if they are expressing in the percentage and they are excluding this 2,000, then they are going with this answer as 50%. This is the correct answer. And if they are not excluding this 2,000, they may go with a 40%. That is a wrong answer. So be very careful that we have to identify that what is the numerator, what is the denominator, what is the multiplying factor. Means your formula should be very strong. Clear? Now again, the various health workers which are posted at the various centers are very, very important, and we should be knowing their population coverage. Now one thing is, we know the population coverage of the various health centers, like a sub-center in the plain area is 5,000, in the hilly area 3,000, the community health center in the plain area 1,20,000, in the hilly area 80,000, or the primary health center 30,000 or the 20,000. So remember the 2 points here is that if they had not mentioned anything, always go with the area of the plain. Second, if they had not mentioned that the exact value, we have to go with the nearest value. One thing. Now second, we should be knowing that what workers are posted in that particular area, and that will be the population of that particular worker. Now suppose if a question is asked like this, that in the middle of a night a pregnant woman starts having a labor pains, and which worker should be called for. Now here the catch is that which worker is called for. Now if they are saying that which worker is called to conduct the delivery, it means they want the home delivery, and then it should be the multi-purpose worker female. But if they say that which worker to be called by the relative to go to the hospital, means they want to go to the hospital and some health worker is going along with them, and this is the worker none other than the ASHA worker as a part of Janani Suraksha Yojana. She is going with a pregnant lady. So here the correct answer is the ASHA worker. Clear? So if they are trying to call at home for the delivery, then why I had chosen the multi-purpose worker female over the traditional birth attendant? Because the best person to conduct the delivery is multi-purpose worker female. She can take a help of a TBA in that area, but if you have to choose one out of them, it should be the multi-purpose worker female. And we know that Anganwadi workers, it is not related to the MCH care. Now another question is, if a question is that worker posted at the 30,000 of the population conducting the delivery. So quickly the question is, or the thing should flash in your mind, or concept should flash in your mind, that 30,000 means they are talking about the primary health center. Now multi-purpose workers are not posted at the primary health center, so it is out. Because you may be confusing that they are asking that she is conducting the delivery, you may be confused with a multi-purpose worker female. She is conducting the delivery, but here the catch is population is 30,000, which is not for the multi-purpose worker because they are posted at subcenter, which is the 5,000 population. Okay, so here the option left is the health assistant female because she is posted at the PSC, covering the 30,000 population, conducting the delivery, maintaining the records. Not the ASHA worker. Again, they are not posted at the primary health center. Clear? Now, another question is, if I say that mother is taking the baby, and here the one catch is that it is taking the baby to the subcenter. It means either they are talking about the population coverage or they are talking about the workers which are posted at the subcenter. We know that multi-purpose workers are posted and it is covering the 5,000 population. Clear? Now, here if a question is asked like this, that the baby is having the loose motion and the guard of that center says that just wait, the sir is coming. So, sir means he is referring the health worker who is posted at the subcenter. Now, don't consider that only the doctors are being called as a sir. Now, any health worker, because he is a very reputed person at the subcenter treating all the patients, so obviously he is also called as a sir. So, no confusion with the medical officer because medical officer is not posted at the subcenter. Now, multi-purpose worker male, yes, posted at the subcenter dealing with the treatment of the basic problems. So, this could be a possibility. Now, health assistant not posted at the subcenter and the physician is not posted at the subcenter. So, here the correct answer is multi-purpose worker male. So, like that we have to come to the conclusion. Clear? Now, another very confusing area is that if we have to identify that which test we will be using to compare the various groups. Now, please listen carefully that if we are trying to solve this type of questions, now three things you have to see in the question. The first is you have to see whether this data given is a quantitative data or it is a qualitative data. One thing. Now, second, once you had decided it is a quantitative or qualitative, then you have to look for that how many groups they are comparing, whether they are comparing the two groups or they are comparing the more than two groups. And the third thing is that if they are comparing the two groups, then these two groups are the same groups or the different groups. So, these are the 3 points which we have to look, and this will decide that which test we will be using for analysis. Okay, like if I say in this question that a new anti-diabetic drug is to be tested and the blood sugar is recorded. We know the blood sugar can be measured. So, this is a quantitative data. So, they are talking about the quantitative data. One thing is out. Now, what they had done, the one group is that they had selected the patients and they had initially checked their blood sugar level. So, this is my first group before giving any drug. Now, what they had done, that they had given the new drug and after the 1 month again the blood sugar was checked. So, this was the second group 1 month after the intervention. So, here the quantitative data is there and they are comparing the two groups. Now, the third thing is we have to see whether this is the same data or these are the different data. So, these are the same individuals before giving a drug, their sugar was checked and after giving the drug their sugar was checked. So, two groups we are comparing in the quantitative group. So, we have to use the student t-test. Now, question is whether we have to use the paired or the unpaired. So, these are the two groups before and after the intervention. So, obviously we are using the paired t-test. Okay. So, if they are comparing the two different groups, then definitely we will be using the unpaired t-test. If they are comparing the qualitative data, the two different qualitative data, then we will be using the chi-square test or even a more than two qualitative data. And ANOVA test, if they are comparing the more than two groups, but it is the quantitative data, we will be using the ANOVA test. Clear? Now, suppose if another question is asked like this, that to know the effect of a new antihypertensive drug, the baseline blood pressure of the 100 hypertensive patients was recorded. So, this is the baseline blood pressure we can measure. So, this is your quantitative data, one thing. Now, the second point is that what they had done, they had divided these 100 patients into the two groups and the separate drug was given to both the groups. And what they had done, that they had taken the reading of the post treatment. So, they had taken an initial reading also and they had taken a a post reading also. So obviously they had making the 4 groups, but a question is that a post treatment recording of these 2 groups. So here they are just telling that we are comparing the 2 groups, but these are the 2 different groups after the treatment we are comparing. We are not comparing the same group before the treatment and after. So they are comparing the 2 different groups after the treatment. So the 2 groups, the 2 different groups with the quantitative data. So your answer is, it is your unpaired t-test. Clear? Now another area is of the normal distribution pattern or the Gaussian curve. So before going this, we should be having the basic idea that how this Gaussian curve is, means how much is the population is being covered in the plus minus of the 1, 2, 3 standard deviation. Now this is a center point where it is correlating with the mean, median or the mode, and the area which is coming under the plus minus of the 1 standard deviation, it is covering the 68%. I am going in a round figure. Now the area which is between the plus minus of the 2 standard deviation, it is covering around the 95% population, and the area which is going between the plus minus of the 3 standard deviation, it is covering your 99% of the population. Now, the important point is to make this question little bit difficult. Sometime the examiner asks from you that how much is the area outside. So outside of this plus minus of 1 standard deviation, outside is the 32%, because 68% inside, so 32% outside. And please listen carefully, if they are asking only on the one side above the plus 1, so it will be your only the 16% will be on the higher side than 16% will be on the below minus 1 standard. Clear? So read the question very carefully, whether they are asking inside or within the range of the plus minus of 1 standard deviation, or total outside. Outside total will be the 32%. On upper side means beyond the plus 1 standard is only 16%, below minus 1 standard deviation is only 16%. Sometimes they ask inside also this half of the area. If they ask that area between the mean plus 1 standard will be only the 34%. The area between the mean and minus 1 standard deviation is again only the 34%. If they are asking both plus minus is 68%. So this is the basic concept, should be clear in your mind before going to these type of questions. Now if a question is that 20 children with a mean weight of 40 kilograms with a standard deviation of the 2 kilogram. So here the total number of the children are not required, that mean weight is 40 with a standard deviation of the 2 kilogram. So we know that 68% are between the plus minus of 1 standard deviation. So 38 to 42 is 68%. Here examiner has given you a catch, they are writing 98. So कभी कभी नींद में होते हैं ना, तो 98 को भी 68 पड़ जाते हैं, because आपके दिमाग को पता है कि it is 68, you may go with this option, and the examiner is very smart and putting this choice on the number 1, because they know that some of you can be trapped at this point. So be very careful. So this is 98, not the 68. So this is again out. Now we know that within a plus minus of 2 standard deviation, the 95% children fall. So yes, this could be the possibility. Now 99% is within the plus minus of 3, but they are giving a value of the plus minus of the 1. Then this is again out. And in the last choice again they are giving a value of the plus minus of the 2, and that is not covering the 99%. So this is also out. So your correct answer is this. Okay. Now if another question is asked that in a group of the 50 children with a mean weight of the 50 kilograms with a standard deviation of the 2 kilograms, then what is the correct statement? Now the correct statement is that we know that within the plus minus of 1 is the 68% and outside is the 32%. So if they say that 48 to 52 is the range of the plus minus 1 and 32% is outside, we say yes, and we just mark it and go ahead, because suppose if you are having a short of time and you say okay, this is the correct answer, I am not having any doubt, and you jump to the another question. But please give 5 seconds minimum time to read the other choices also, because there might be some googly ball sitting in the end. And what is the googly ball? We'll see that 95% children is between the 46 to 54 within a plus minus 2 standard deviation. Yes, this is also right. The 16% of the children are below 48 kilogram. Now here it is a trick, because 48 kilogram is the minus 1 standard deviation, and we know that 16% is below. Little bit tricky, but this is also right. So here the best answer is that all of the above are right, but maximum of you, if they are not knowing the outside concept, and I may think that may land up in the answer 2, that as I could see again that many of you are answering this answer 2, but this is not right, because here the concept they had utilized of inside and the outside both. So all the 3 statements are correct. So the correct answer is answer number 4. Clear? So this is how you should be able to understand the concept of the normal distribution. And the one more question commonly asked is that what is the relationship between the mean, median and the mode? If it is a normally distributed, the all 3 are equal, and if it is a right skewed deviation, the mean is the maximum followed by the median then the mode, and if it is a left skewed deviation, then the mode is maximum followed by the median and followed by mean. So remember this point. Okay. Then very commonly they ask about the malaria treatment. Now again here, while talking about the malaria treatment, then you should be giving the importance to the 2-3 points. The one thing is that whether they had given you the species. As per the national program, the treatment of choice for the Vivex and the falciparum is different. Now the second is you have to see that in which area the person is living, especially if it is the falciparum, because in the falciparum the treatment guideline is different for the individuals living in a northeast area and the other areas. And the third is that you have to see whether they are talking about a female, so female is pregnant or not, because we have to make some modifications in the treatment. And then the pregnancy, the modification is about the primaquine, and for the falciparum the modification is about the treatment in the first trimester. Clear? So suppose if a question is asked like this, a person is living in the Mumbai. So Mumbai is obviously it is a non-northeast states other than the northeast. This is a one catch. Now has been positive for the falciparum malaria. So falciparum malaria in the area other than the northeast states, the drug of choice is the artesunate sulfadoxine and pyrimethamine. Clear? Now if they are talking about that a person living in the Assam or person living in the Mizoram, so that is a northeast area, and in that case for the falciparum the drug of choice should be the artemethyl lumefantrine. Clear? So correct answer is the artesunate sulfadoxine pyrimethamine, and if they didn't mention the falciparum, if they mention it is a Vivex, then your answer will be the chloroquine. Clear? Now the next is if they say that the drug of choice for the falciparum, this is a one catch, in a lady who is having the 8 weeks pregnancy. Now in a lady who is in a first trimester of the pregnancy with falciparum, the drug of choice is quinine, and it is in all the states of the India. So if they didn't mention whether the lady is in the northeast state or other states, no problem, because everywhere in the first trimester the drug of choice is quinine. Now it is chloroquine for a Vivex malaria, and they are talking about the falciparum, so this is not. The artemethyl lumefantrine or the artesunate sulfadoxine pyrimethamine, they are given in the second or the third trimester of the pregnancy, not in the first trimester. And if it is in the northeast states, yes, artemethyl lumefantrine, other states the artesunate sulfadoxine pyrimethamine. And one more point is that primaquine is contraindicated in pregnancy in both Vivex and falciparum. Clear? Now another question is that we have to go with the correct statement. So here we have to go with the each statement point by point, and we have to see whether this is correct or wrong, because we have to answer that which is the correct statement. Now chloroquine is the drug of choice for falciparum, no, because this is the drug of choice for Vivex, so this is out. Artesunate therapy is given for falciparum malaria. So artesunate is given for falciparum but not in the first trimester, so this is also out. Now dose of the primaquine in the falciparum malaria is a 0.75 milligram per kg once Yes, this is a correct answer because falciparum we are giving once, and in the Vivex we are giving lower doses for a longer time. 0.25 milligram per kg daily for 14 days in the Vivex infection. Now, dose of the primaquine in the Vivex malaria is 0.75 per kg for 14 days. No, 14 days, but this is 0.25. So, this is also a wrong answer. So, the correct answer is the option C. So, in this way, we have to go with the each statement. Yes, it will take a little bit time, but the treatment should be clear in your mind, and you have to just look for the correct answer. Now, another area is the rabies prophylaxis. Now, here a very important is that we should be reading very carefully whether they are talking about the pre-exposure prophylaxis or they are talking about the post-exposure prophylaxis, because again, as I said, that we might be working at a subconscious level and we may make this mistake, because what we had seen from the experience of the senior students, that if they are not having a proper sleep the day before the examination, and in the first paper they are still able to focus, but in the second paper they are very tired and they are working only at a subconscious level. And we know that a second paper is the clinical paper. So, in the clinical paper, now they are giving you the clinical scenarios. You have to identify the keywords and we have to connect the dots. So, if you are missing any single keyword, then your answer may change. An examiner is very smart and they are giving the choices accordingly. So, be very careful. First thing, they are talking about the pre-exposure prophylaxis or the post-exposure, means whether the dog has given you the bite or not. So, pre-exposure means before the bite of a dog or any rabid animal, we are giving for the safety, and the schedule we are following is 0728. Clear? These are the days when we give the vaccine. And remember, the 0 is when we are starting our first dose, okay? And here the schedule what we follow is the intramuscular. Now, the rest all are not a pre-exposure, they all are the post-exposure schedule. Now, if they are asking about the post-exposure rabies prophylaxis, now here again there could be the 2 points we have to remember, whether they are talking about the post-exposure in those individuals who had already received the vaccine earlier, or those individuals who are fresh like me and you, that we had not received the vaccine earlier, and if we had accidental bite, then what should be the schedule. This is the one thing. Now, second is that whether they are talking about the route, because the intramuscular schedule is little bit different from the intradermal schedule. Clear? So, if they are asking what is the schedule for the post-exposure rabies prophylaxis, they didn't mention whether the person is pre-vaccinated or not. So, 03, yes, this can be scheduled if a person is already pre-vaccinated as 0728. So, this could be intramuscular schedule. 0371428, this can also be if it is a non-vaccinated individual. Now, the full intramuscular schedule we are giving as an SN regime. 22202, this is again a post-exposure schedule for non-vaccinated individual as an intradermal schedule. So, here the correct answer is all we are giving. Okay. So, be very careful because they didn't mention the status, and all can be the post-exposure prophylaxis depending upon the different situations. So, we have to go with the best answer, that is the all. So, here again our success mantra is that we have to choose the best answer or best option from the given choices. Then another very confusing area is that the toxin in the food adulteration, and in the examination we are having a utter confusion between the endemic ascites and epidemic dropsy. दोनों ही एक से लगते हैं, समझ में नहीं आता. An examiner is also very smart. They are not asking the toxin of aflatoxicosis, it is an aflatoxin. They are not asking the toxin of ergotism because it's an ergot alkaloids. They are not asking the toxin of letharism because it is something unique as the beta-oxalyl aminoalanine. And they are asking the toxin of epidemic dropsy or endemic ascites because he knows that confusion is going to happen. And I had given you a very simple trick to remember, and that simple was the endemic ascites we can remember as a word as app. So, we are using the mobile app. So, endemic ascites, if you are not able to remember the full name of this toxin, you can go with any word starting with the P, that is a pyrrolizidine. Until unless the examiner is very smart, giving all the toxins starting from the P. But once they are asking the toxin, then definitely they have to give the different toxins to make a question sensible. And it is only the one toxin starting with the P is the pyrrolizidine. Now, if they are asking for the toxin of epidemic dropsy, then how to remember? We know that some of our friends might be doing the dental course, that is a BDS course, and you can remember as in BDS, EDS. So, any toxin of the epidemic dropsy starting with the S, that is the sanguinarine, is the answer. So, this is the silly way, I know, but this is a very useful way to remember in the examination. And we should be knowing a few important points also, because they had asked that what is the agent in the epidemic dropsy. This is the argemone seed which are being mixed in the mustard seed, or they had asked that aflatoxin is what type of the toxin. It is a liver toxin, can cause the liver cancers. And pyrrolizidine, it is again a hepatotoxin which is causing the ascites. So, these are the important points what we have to remember about the food adulteration. Now, another very important section is the vitamin A problems. The vitamin A deficiency, we know that it can lead to blindness, and that blindness is preventable. That is the most important reason that why we are focusing on supplementing the vitamin A, because the blindness caused because of the deficiency is absolutely preventable. That's why we had started giving the vitamin A in our national immunization schedule along with the vaccination. Yeah. So, the question is that what is the most important sign? The most important sign, no confusion, it is the Bitot spot. Now, they are not asking the first symptom. The first symptom is the night blindness, which is not an answer. The first sign is the conjunctival dryness or the conjunctival cirrhosis, but they are asking which is the most important clinical sign in the screening process in the school or while doing an examination of a child is the Bitot spot. Now, another question was asked that which is the most sensitive indicator of the vitamin A deficiency, and this is the serum retinol level, and it should be less than a 10 microgram percent. So, it should be less than 10 microgram percent is the serum retinol level. Now, the next part they ask is about the doses of the vitamin A. Now, if the doses we are talking about for the prophylaxis. Now, we are giving the total 9 doses, and total amount of the vitamin A what we are giving is the 17 international units, and if our age is less than 1 year, we are giving the 1 lakh international unit per dose or the 1 ml, and if the age is more than 1 year, we are giving the 2 lakh international units per dose or the 2 ml per dose at a gap of 6 months till 5 years. But if they are asking about the doses for the treatment, now the treatment we have to give a larger amount of the doses. Here we are giving the 3 doses within 1 month span. So, we are giving the dose today, then the next day on the day 1, and we are giving after the 2 to 4 weeks. So, the 3 doses, heavy doses we are giving within a 1 month, because we know it's a fat soluble vitamin can store in the body, and the amount will be the same, means depending upon the age. So, the question is that in a children of more than 1 year for the treatment, so obviously it will be the more than 1 year, so the 2 lakh doses will be, and it will be the 3 lakh 3 doses we are giving, and per dose is the 2 lakh international units. Okay. Now, another very important area from where the question is asked is from the intensified iron plus initiative or anemia mukt Bharat. Now, here the question is that who are the beneficiaries. Now, we know that in the ICDS centers the beneficiaries are the 0 to 6 years, but in the iron plus initiative or the anemia mukt Bharat program, we are not giving anything till 6 months of the age, because we are only giving a breastfeed. We are not giving anything from the top. So, we are also not giving the iron supplementation. So, 0 to a 6-month age is not the beneficiary. Now, other 6 beneficiaries are the 6 months to 5 years, then 6 to 10 years, the 10 to 19 years, then we are having the 20 to 45 years, and the pregnancy and the lactation. This is one thing. Now, the second point is that their frequency. The frequency in a child of 6 months to 5 years, we are giving twice a week, while in the pregnancy and lactation we are giving daily, and in the rest we are giving weekly. So we are having mainly the weekly prophylactic supplementation, except the pregnancy, lactation and the children less than 5 years. This is again a very important section. And the third is, sometimes they will ask in such a detail that how much should be the composition of iron and folic acid and the frequency, all the 3 things in that. Now, how smartly we have to solve this question and focusing on saving our time. So, if a question is asked that what is the dose of iron folic acid in the adolescent girl? So, obviously the adolescent girl is non-pregnant. So, we are giving prophylactically, and in this we are giving the weekly supplementation. So, quickly we will see that this daily is out and this daily is out. Now, we are left only the 2 choices. Now, we have to just focus on these 2 choices. Now, we know that adult iron tablet composition is now 60 milligram of elemental iron and 500 microgram of folic acid. So, 60 milligram iron, 500 folic acid, yes, this is an answer, because here it is the 100 microgram of folic acid, this is out. So, the correct answer is 60 milligram of iron and 500 microgram of folic acid. So, see how quickly we can reach to the correct answer. So, this should be the strategy. Now, this is again a very, very important area, and where the question is asked and we had confusion in solving the questions. Okay, so this is based on our Vision 2020 program and the criteria of classifying the blindness. Now, the cutoff level of the blindness is if the vision is less than 3/60 in the better eye with the best possible correction. And we should be knowing this classification before answering the question, that if we are having the vision between 6/60 to 6/18, that it is a no visual impairment or the normal vision is there. And if the vision is less than 6/18 to 6/60, mind it is up to 6/60, it is either the low vision or it is the mild visual impairment as per the old or the new classification. The old classification says the low vision, the new says it is a mild visual impairment. If it is less than 6/60 to the 3/60, it is coming as an economic blindness or the severe visual impairment. And if it is less than 3/60, obviously it is the blindness, but in the old classification we say it is the social blindness till 1/60. Less than 1/60 to the perception of light is the manifest blindness than the absolute blindness. Clear? So, we have to see that which is the better eye, what is the vision in that better eye, and what is the group in which it is coming. So, coming to the question is the person with a vision of 6/60 in the right eye and the 3/60 in the left eye. So, obviously the vision better is in the right eye, that is 6/60. Mind it is not less than 6/60. So, if it is 6/60, so obviously this is coming in this group of a low vision or the mild visual impairment. So, we had thought the answer in our mind and now we have to look the choices. It is not the economic blindness, because for the economic blindness should be less than 6/60. This is only the problem which can happen. So, it is not the economic blindness because it should be less than 6/60. It is 6/60. It is not the social blindness because it should be less than 3/60. It is not the manifest blindness because it is should be less than 1/60. So, the correct answer is it is the low vision. I am having all the mixed answers of A, B, C, D, all is there. So, be very careful that we have to see that whether they are talking about the less than or exact value in the better eye, and we have to go with our classification. And this is as per our Vision 2020. And the goal of this Vision 2020 was that we have to avoid the preventable causes of blindness, and we have to bring the total blindness prevalence to the 0.3%. And another very important section which has been asked is that what are the diseases included. Remember, the onchocerciasis as per the WHO guideline, but this is not included in Indian guideline. We had a glaucoma, diabetic retinopathy, and the corneal diseases or the corneal ulcers in the disease other than the common diseases. Then the next section is the insects, the very commonly asked section, and this will be the last question of this session. The very important section, they either give you the image of the insect or they will ask you that what diseases are caused by the insect without giving the image. So if we talk about the various insects, this is your house fly, and this is transferring the infection from one to another, all the waterborne infections or the trachoma. This is the louse, and we know that the diseases caused by the louse we remember by ETR, epidemic typhus, trench fever, and the relapsing fever. We are using the MTR masalas, you can remember as an ETR. So epidemic typhus by the louse, trench fever, relapsing fever, and the pediculosis. Now another type of the typhus which is caused because of the flea, and that is the endemic typhus and the plague. Now please listen, if they are talking about the bubonic plague is not caused because of the red flea, because this is through the respiratory route. Okay. Now the next is the mite. It is causing the scrub typhus, another type of the typhus, and the rickettsial pox. And the very important feature of the scrub typhus is the presence of Ishar. Then very important, they ask you the image of these mosquitoes, and these three mosquitoes are very important. Now you have to see their sitting position of these adult mosquitoes. Now if it is making an angle to the surface, it is your Anopheles mosquito causing the malaria. If it is sitting parallel to the surface without the white spots on the body, it is your Culex mosquito, and this is causing mainly the filariasis and the Japanese encephalitis. Breeding in dirty areas can fly up to the 11 kilometers. So if we are investigating or doing an epidemiological study of an epidemic of Japanese encephalitis in a village, we have to look for the breeding sites in another village also. And if it is resting parallel to the surface with the white spots on the body like a tiger spots, it is your Aedes mosquito, and it is causing the dengue fever, chikungunya, yellow fever, Zika virus disease. Although this is a tiger mosquito, but this is able to fly only up to the 100 meters, and this what we are using. Advantage of this is while controlling the breeding at the airports or the seaports to prevent the entry of the yellow fever, where we are keeping our 400-meter radius area free from the breeding sites. And what are the breeding sites for these Aedes mosquito is the artificial water collection. Okay. And this is your Mansonian mosquito, hardly asked in the examination. And this is your Ridovit bug causing the Chagas disease. And this is again a very important insect, is the sandfly, and this is causing the diseases you can remember as the COSO, what we say as a mnemonic, that is the Kala-Azar or the visceral leishmaniasis, the oriental sore, we are having a sandfly fever and the Oriya fever. Okay. And one beauty is that this can fly up to the 6 feet height. So if you have to sprinkle the insecticidal agent, it is only sprayed till a 6 feet height, and this is causing a disease that is a leishmaniasis, and that said that the leishmaniasis is a disease of low altitude. And this is a tick, hard tick and the soft tick, and the question asked is the KFD. So in the India, the KFD is caused because of the hard tick, and outside India, this is caused because of the soft tick. So based on this, a few questions are asked, and the one question straightforward, that vector of leishmaniasis is none other than the sandfly. The vector of the KFD in India is the hard tick, or the vector of the filariasis. Now remember one point, that filariasis is mainly caused by the a Culex a mosquito, but it is seen that in some areas it is caused by the Anopheles and the Aedes also. So here the best answer to this is that it can be caused by the all mosquitoes. Clear? So these are the few important areas which I thought that may create a confusion, and you should be able to understand that where the mistakes can happen, and if we can rectify those mistakes, then definitely we are going to do the wonders in the upcoming examination. So in the last I can say that you have to push yourself, because you are the only person that you can do the hard work, because our goal is to achieve the a license degree from the national board, and we all are waiting at the finishing line to welcome you all that yes, you had made it, you had done it. So with these words, I would like to thank you all for this session. So God bless you, all the best, bye bye, take care.